The next speaker, in fact, he's going to give two talks, one before lunch, one after lunch, is Mr. Sinderby. And he's going to start with patient-ventilator interaction during Nava and other modes of assisted ventilation.
All right, so I'm going to talk here two lectures now about Nava. The first one is going to be about patient-ventilator interaction. And we're going to talk about what we think are the strengths, like at least at first thought. And the second lecture is going to be if the patient actually knows what he's doing while he's doing it during Nava. And that's going to be after lunch talk. So first of all, I come from St. Michael's, and I'm a PhD scientist. And I should actually not talk about these things because I'm not in practice, but I'm going to do it anyway since you are forced to listen to me. So going back to evidence-based medicine, which I know very little about, I think I take the side of John in terms of I'm a physiologist. I think I believe a lot in physiology. I think that there is good space for evidence-based medicine if you use it right. And the thing is also, do we respond to it? And for reasons to change technology and practice, I think if we talk about trials that has been done that actually do make a difference, if we look at, for example, daily spontaneous breathing trials, there is a number of trials that all show that if you get the patient to breathe at least once a day, he gets off the ventilator faster. And how many are using spontaneous breathing trials protocolized? I don't know. The other thing is daily interruption of sedatives is another thing which, at least in North America, can be discussed. I think there's a very big difference between Europe and North America in this case. But here is again, same thing. You take the patient off the sedative once a day. Why you do it once a day and not protocolized, that's another whole line of issues. But it seems to also that shorten the time on mechanical ventilation. And then we have like the ABC trial that just came out a few months ago, last year, where like Shiraj, together with Vesili and Kress, shows that you get less time on ventilator, less time in coma, less time in ICU, less time in hospital, lower cost, less likely to die after 1 year, and so go on. And this sounds all great, correct? And the thing is, what did they do? They took away the sedatives, and they took them off the ventilator at the same time. I don't know if this is a pretty sight in the ICU. According to the paper, it's not so bad, apparently. But if this is really applicable, really, I don't know. But I'm not in this. But in terms of evidence-based medicine, if nobody believes in this, I don't know what evidence-based medicine can show. Impaired patient ventilator synchrony is a more diffuse topic that has been discussed a lot. So I looked upon what evidence do we have there. Well, Till did a study, and there's another study by Chow in chronically ventilated patients or hard-to-wean patients. And they both show that if you don't have synchrony, the patient stays longer on the ventilator. It also shows, like what Marco Ranieri shows with his group, is that if you don't have a good patient-ventilator synchrony, it seems to impair sleep. And it just came out a paper that it doesn't matter really what ventilator mode you use. I think it's what Marco was onto. It's the synchrony itself that makes the difference. If you ventilate well with pressure support, it's no problem. If you ventilate with Nava, it might not be a problem. If you ventilate with PAV, might not be a problem. Even if you have controlled mode and the patient is not too negatively affected, it might not affect his sleep. I don't think it's the mode itself. The machine in itself just delivers pressure or flow or volume. It's a pretty dumb machine in the sense of what it does. When we go to ventilator-induced lung injury, I think everybody who is doing in a lab a fixed kind of like lesion to the lungs or something like that, which is reproducible, we'll see that both PEEP and tidal volume has an immense impact on the recovery after those insults to the system. When you go to the clinic, it's more difficult to show it, of course, because it's so variable and it's so diffuse. And then comes, like, I think the topic that has been going on for years. This is ventilator-induced diaphragm dysfunction, which is kind of a thing that for basic scientists has been a big challenge, very interesting. Nobody ever thought about it as anything important until, like, Sanford Levine showed, like, a few months ago, that a patient who is waiting, so who is a donor, is brain dead, stopped breathing, stays on controlled mode ventilation, compared to a patient who undergoes surgery. In this study, they showed that something like less than 72 hours on the ventilator reduces the fiber diameter to 50%. You have severe atrophy. And I think what everybody has thought in the past is the diaphragm is a muscle built to work. If you take away that, it forgets what to do. It doesn't know, it gets completely confused. It just starts to disappear. And when we combine this with, say, lung injury and situations where you get, for example, high release of TNF-alpha and so on, TNF-alpha is toxic to the diaphragm. It disappears just of TNF. If you put myoblasts, which Michael Reed showed, you put myoblasts to grow and you put TNF-alpha in. After half an hour, you have no more myoblasts. They are gone. So there's a lot of factors here that in both experimental medicine and in evidence-based medicine now has kind of come together, that both impaired ventilator synchrony and breathe in itself and less sedation. So we have to have patients who are breathing spontaneously. They have to be synchronized and so on. I think we are at that point today. The thing is just how to do it. So now, if we take just the issue about prolonged mechanical ventilation before I go on with Nava and synchrony, the thing is, what does it cost to keep the patient in an ICU? 2 studies of over 250 hospitals in the US has shown that it adds $1,500 a day to put the guy on the ventilator. That's what the RT department costs, that's what the ventilators cost, and that's the whole cost. I was asking at the, what is called the Brussels meeting this year, I was asking like some guys there if anybody knew what it would cost in Europe, and I was given a price of 1,800 euros a day, which sounds more expensive, but I can believe it because in this case, it's physicians who spends a lot of time on the ventilator. So it might be that if you calculate a different way, but it's a significant amount of money. So if you change 3-4 days in the ICU, it's going to do a lot of things to your budget. So when said all this, and we go back to what we have today, it's like we are looking at waveforms today. So if you take a look at this slide, so what do you see on this slide that is different? It's like about 40 minutes difference in time between these two left and right side. I mean, you see on the right side, you have something that at the lower part, you would consider that this is probably a synchrony. On this side, the patient is doing great. Now, this person is not sedated, he's awake. What you see at the top here, this is diaphragm activity. On the left side, you see a few little blips, but you see technically no diaphragm activity. The guy is awake and he's apneic. On the right side, you see the guy, he's not apneic, he's breathing. And he's perfectly synchronized. This is what Rolf talks about, and you showed it nicely in one of your studies, that you can get a patient, awake or sedated, to synchronize himself to volume control with no problem. And why? Because you learn how to do it, I think. We are very fast learners. The thing is, yes, if you stay on this side, well, I think a guy like Sanford Levine would say from his data today that this is no good. And this patient actually stayed for about 2 years in the ICU. Now, is that because we don't want to try to improve this? No, it's because we are blind. You can't see this thing you see at the top. It doesn't exist in the past. Now you can see it, because now you get it on the ventilator. This is another one. Now we have pressure support instead. This is not volume control. So, I mean, has anybody ever had a patient who is apneic in pressure support? If they trigger a ventilator, they breathe. Anybody who is against that assumption? Or can you say that if you are not breathing, you can still be on pressure support and trigger a ventilator? Well, you can. This guy is not breathing. This is a completely apneic patient. And the diaphragm, in the diaphragm. If you look upon this patient, you will see. So this patient is using neck muscles and upper airways more or less just to distend upper airways or the upper parts of the lungs to just kind of trigger the ventilator. And then in pressure support, you get a breath that is so much assist that you don't have to breathe. And for the diaphragm, you can forget it. You don't need it necessarily. You can set up this in yourself. If you sit on like with an electrode down to measure diaphragm activity, you can easily run the ventilator in pressure support without using your diaphragm. You put the same patient on Nava, and here you see on the right side, the The diaphragm activity is there because in this case, if you don't use the diaphragm, you will not get any assist. So the result in that case will be no pressure and no ventilation. So you get an apnea in that situation. Here you have a central apnea with ventilation. So now we come into this whole topic about synchronized assist, asynchronous assist. What's the difference between the two? Well, one is that you are following the ventilator or the ventilator follows you. Synchrony. Asynchrony means you are not following the ventilator or the ventilator is not following you. Whichever way it goes, that's asynchrony. If we get asynchrony, well, we get into agitation often. So if I'm not able to keep up with the ventilator, either I can't trigger it, or if I get too much so I can't stop it, it will affect me in some way that I will be agitated. And then we have this wonderful thing called sedation. So we can just take away the agitation and kind of overrule the patient and say, here you go anyway, because I've decided this is good for you. And if it is good or not, I don't think anybody knows. This is, again, one of those future randomized trials we should do. But if we go down to, say, the pathway of synchronized assist and ventilation, that means that if we say, like, for example, that when Jennifer and I go to the cottage, which is kind of like in a bit of a dirt field, so we have this beautiful big sub that we rented 1 year. It gets stuck in the mud. And I tell Jennifer, okay, I'm going to push and you're going to gently, this is like with manual. Release the clutch and just come back up. So what she does is she revs the engine, releases the clutch like bang, and I get sprayed of mud and the car doesn't move anywhere. And I didn't even have a chance to push at the same time. So then we practice a few times. Now I'm drenched in mud. But anyway, when we get the synchrony, we finally get the car out of the hole because joint forces work better. Asynchronous, well, that is when you are at that point. Somebody's pressing the accelerator when the other guy is not pushing. You're not going anywhere because you need both forces to get what you want. Otherwise, the assist that you push has to be so high that it overcomes and does also your work. So, breathing then, which we think is a simple thing, and I'm going to dwell on this topic quite a bit because this is where the synchrony comes from. So if we go to a slide here, sorry. When we breathe in, our respiratory centers are sending a signal out that will eventually go to all inspiratory muscles. In this case, we're just illustrating the diaphragm. So we have a phrenic nerve transmission. We electrify the muscle, so to speak. That's the way to tell the muscle now the contractile engine should start. And once the contractile engine starts, well, then we have the contraction, chest wall expansion, and inspiratory flow. Everybody knows this. Very few people knows what's goes on the other side, the neural feedback. What is actually happening when you breathe in? What does the brain know when you breathe in? How much information do you receive back? And I'm going to try to share some interesting minutes here with you to try to go through this. And that's, if we look here in the center of this slide here, this is what you saw on the video. This is going from top, the brain. So we have an output, central generating pattern, but this can be overruled by speech, by sedation, by many things. We pass the signal down the spinal cord, through the nerves, and if we don't have a problem with the conduction of the nerve signal, then we will get the diaphragm excited, and we will have, like, following the electrical activation of the diaphragm, which is about here, we will have a muscle contraction, then this will affect the chest wall configuration, we will have a lung distension, the alveolar pressure will be decreased. If we have intrinsic PEEP, this is at a time when it will play a role. Respiratory system compliance will be the load we work against. We will decrease the alveolar pressure if we reach the lung and it's kind of moving outward. Airway opening pressure, flow, and volume will increase, so you will actually get air into the lungs. And depending on the dead space that you will have some alveolar ventilation. And if you have say a healthy lung, you will have a normal gas exchange and your blood gases will be normal. And you need like a breath, like say 10 times a minute of about 500 ml. And that's what everybody of you are doing here now. And the ones of you who are sleeping have lowered your breathing frequency. And the ones of you that just woke up and are yawning are taking that big recruitment breath. So this is going on at all times. So why do we yawn? Why do we change our breathing pattern and all these things? Because we have built-in receptors in this system. But before we go there, I will just show you what happens when we get sick. So this is the diaphragm activity in a healthy subject, half a liter tidal volume, a very low activity, about less than 10% of the maximum activity. Go to a patient with COPD who lives at home, 45 millimeters of mercury, he's like borderline chronic hypercapnic. This guy has about 5 to 7 more times the diaphragm activity than the healthy one in order to get the same tidal volume. Also a dead space problem, so he has to breathe a little bit faster. A patient with a post-polio syndrome has the same kind of situation. He has to use more electrical activity to get the same volume. This is the cost of breathing that disease does to you. The other thing is, when you come into an ICU, and this I think has to do with Sanford-Levine study again, but Franco Lage showed a few years ago, very interestingly, that first he reproduced data that was very old from John Moxham that showed that the maximum pressure that you measure in a patient in the ICU when he is ready to be weaned, so he is not sedated anymore, you ask him to do a maximum maneuver to generate the pressure. And what he found as pressures is in the same range like as Moxham found. The pressures are about 25% of what they is in a normal subject. So a patient in the ICU have lost 75% of his contractile force. But we never believed that, because who believes in voluntary maneuvers? So what Franco did, he put like a magnetic stimulation on the neck. So he supramaximally stimulated the phrenic nerves. So he gets, of course, a lower pressure, but the relative reduction in force compared to normal is still 75%. So when you ask the guys to do it, they actually seem to do what you ask them, and that is good. But the thing is now, I think we know today that patients who are kind of in a Chicago ICU, ready to be weaned, that's what the physician judged, this patient has a diaphragm activity that is 75% reduced. And there is no difference between the guys who are successfully weaned and the guys who are not successfully weaned, and that strikes me. The force is the same in the one who comes out nicely and the one who fails. So why is that? Well, it's not so simple as just force to breathe. It's load too, and you don't have any clue about the load in these patients. So, to respiratory feedback. So now when we have this thing going down this path because we breathe in, what then happens at each level here, we have things go back up to the brain. So if we start with the blood gases, well, we have chemoreceptors. They will tell you what's the O2 pressure, what's your pH, what's your CO2 levels, and so on. And we are so well defined that some basic scientists today think that we even have PCO2 receptors in the lung. So we actually have receptors there that are sensitive to CO2 and therefore maybe also pH sensitive. So they are like, they're pH sensitive, and the CO2 is the one that changes the pH. So these are very neat things and very fast responding. And that's we have so that we know that our blood gases are right all the time. This goes automatically. We don't have to think about it. We have cardiovascular afferents. Cardiovascular afferents is kind of like, with positive pressure ventilation, it's kind of a weird thing because we are developed to breathe in with a negative pressure around the lung. We're not supposed to breathe in with the positive pressure into the lung. So how the cardiovascular afferents respond to this is not really well known, but I think that we might not have the right reflexes, so we might not be prepared for positive pressure ventilation in terms of cardiovascular afferents. Airway and lung reflexes, you know about the rapidly and slowly adapting receptors, but there is about 3 or 4 more of them, and there's like new ones coming out every week today. It's like really a very developing field in basic science. But these are both in the lower airways, in the lungs, and in the upper airways. They sit everywhere. And the interesting thing is the lungs speaks to the upper airways. So there is a communication here. So the upper airways take information from the lung in order to tell, should I contract or relax the upper airways? So should I kind of squish a bit so that we get a little bit more of intrinsic PEEP so we don't let the air go out so fast? Because you can regulate that up here. So it's not only for speech, it's actually for breathing itself. We then have like joint receptors, which Andre de Troyer studied for years. But the thing is, we only know about joint receptors in dogs. We don't know anything about joint receptors in humans. We have phrenic, intercostal, and accessory nerve afferents. And we did some studies which shows that fatigue of the muscle can be felt. So if you see signs of ischemic fatigue in the muscle, you can actually feel it, and this correlates very nicely. And there's a lot of other things that you have here that people have shown that these afferents are very important for you knowing how much the muscle is working. So we know where the lung is, what size it has, if it's edema, if it's stiff. We know that. We have muscle afferents that tells you how much the muscle is working. We have chemoreceptors. We have like feedback with the upper airways, so we can kind of control the PEEP. Everything this goes back to the brain at all times. So why do we have to set somebody in control mode ventilation and keep him there when this beautiful system is at work at all times? Is it because we think it goes away when we sedate? No, it doesn't. It stays there. So just to give an example of these reflexes, I will show you this slide here, or this video. So what you see here is diaphragm activity at the bottom. Here you see volume, flow, and up here is pressure, but there is no pressure applied to talk about here. Now we are just obstructing the airways, or we are clamping the tube. We are not occluding it, we are just clamping it so that it's a severe inspiratory or and expiratory flow resistance. So look here, these are the last 3 breaths before we clamp. These are the next 2 breaths. Look here, from this breath to this, immediate response. It's not like that you have to sit and think about it. It just happens. It's a reflex. And this is in an anesthetized rabbit. This is not sedated. This is something that you can do surgery on without changing blood pressure or heart rate or anything. No corneal reflex available, nothing. This is according to all ethical rules that we have to conform to. So now comes the funny part. How do we integrate the ventilator? Having like the complexity of how we breathe and the complexity of the response, how do we integrate the ventilator? Well, today we are down here. We take measurements of flow or airway pressure, which is a final product. That's like after all the contraction has taken place, that's all after all the electrical activity and the neural output has taken place. So this is very late. So this, what you're trying now to use to feed back the pressure to a ventilator, because the patient has to get pressure. You have to see the pressure before you deliver the pressure. I mean, that means you are like by definition too late. What you're trying to provide has already started. The more intrinsic PEEP you have, the later it will be. The weaker you are, the more difficult it will be to sense it. The more the leak you have, the more difficult it will be to sense it too. So if you look upon the point of delivering pressure, you are actually feeding in a signal from before. So if you trigger now a ventilator and go to pressure support, that's fine. If you take and trigger and then deliver assist in proportion to what you are actually doing as an effort in terms of flow and volume, which PAV, for example, does, then you get into this thing about runaway, because you start to feed back the same thing as you're measuring, and at some point you get an overloop of this and you get runaway. If you look upon using diaphragm activity, or even better, plug straight into the brain centers would be wonderful, but we don't have that switch, so we can't go in there. But if we look upon, say, the diaphragm activity, we pick the signal very high up in the hierarchy. So what we in technical terms do is that we come to a point where we know at the same time as the ventilator starts what the patient is up to do. And if we say then, like as I say here, why do we find patients like this? Because here you see a patient who, if I would then, take away this thing up down here, say this patient has something wrong with his breathing, but what's the problem? Well, his problem is that his respiratory rate is twice that of the ventilator. That's his problem. So he's kind of half synchronized, if we put synchrony terms to it. But why is this happening, and what is it? Because we have no monitors and for a synchrony or any alarms for synchrony. And that's really what we need to know, because this changes from like 1 minute to the next. Dynamic hyperinflation comes and goes. So just to give you a little brief overview of Nava, I think you're all familiar with it, but technically what we have today, and this is coming back to afternoon session, but it's a mode that triggers neurally, gives assist in proportion to your neural effort, and it cycles off when the neural effort disappears. Then you go back to PEEP. It works as you see here When you do an inspiratory effort, what you see when this brain here is starting to get more yellow, all the nerves get more yellow, and also it gets the connection to the ventilator gets more yellow. And that is how you increase your effort to breathe in. When you relax and breathe out, the activity goes away. So the ventilator does the same thing as the muscle is doing. And how can it do that? Because if you look upon this diagram here, it shows simply that the signal that comes out from the brain generates an electrical signal of the diaphragm. This signal goes to the pleural pressure, so efficiency coefficient times the diaphragm activity is equal to the pleural pressure. The ventilator is also receiving the same signal as the muscle. And the ventilators will deliver the diaphragm activity times an efficiency signal, efficiency constant. And that is what the assist that you will give to the patient. So if this one is going down, the patient is getting weaker, then you just increase this one and you compensate. And you have the same driving source on both sides, diaphragm activity. You're just sharing with the patient. That's all you do. And if you have a ventilator minus pleural pressure, you get transpulmonary pressure. This is what expands your lungs, and this is what feedbacks to the brain and tells you what's going on, both in terms of how much effort you do and in terms of how much you expand the lungs, because you will know both, even though you don't think of it. And another thing to look upon here is if you take the diaphragm activity, as you see in this overlay display here, and occlude, you see that the effort and the force is directly related to the increase in diaphragm activity. So, patient ventilator synchrony or asynchrony. As I gave you some examples before, it's very hard to see what happens. But it's kind of other things to it too. And I think it's first in terms of the simple terms that we showed before is like timing. So asynchrony in terms of timing, here you have a slide again. You can see waveforms show that there are wasted efforts over here. So of course this guy has a breathing frequency that is higher than the ventilator actually delivers. But do you see it? I don't know. I mean, these slides are some slides that I just collected. I just got them through the email. I have not been at the bedside. I haven't seen the patient. I don't even know why he's there. But I can tell here that when you look here, you see that the respiratory rate neurally is twice that of the ventilator. So why was the patient like this when they put them on? And when they switched him to Nava, he turned in like this. Blood gases are the same in both situations. Tidal volumes are actually usually lower with Nava than it is with the pressure support or the pressure controlled modes. So here we have timing asynchrony. The other asynchrony, which is more complex, is the amplitude asynchrony. Now we're into this thing with lung injury, and we will talk after lunch about that. But here you have diaphragm activity, and as you can see, it varies. But airway pressure and pressure support doesn't vary. So where do you set the assist level? When the drive is going up and down to try to compensate for changes in load or demand, the ventilator will only do it if you go there and turn the knob. If you have, as we have in Nava, you have that the ventilator is your slave. He's just going to follow you. He's going to give you a relative unloading, take away a certain part of your work, regardless if you take small breaths or big breaths. It takes away a percentage of the work you're doing. Now, in this asynchrony then, it comes this coupling between timing asynchrony and amplitude asynchrony. So this study that we haven't published yet because nobody seems to like it, but anyway, it is a very good study, I think, and I will continue to show the data. So this is low and high pressure support. So this is pressure support in a patient who is taken away so much assist that he's almost into failure. So respiratory rate is up towards 30, and the patient starts to be kind of affected, but not in failure. Then we add 6 or 7 centimeters of what, I can't remember what we did here, but I think it's 6 centimeters we added to what we call a high level of pressure support. Then what we do is, during Nava, we lower to the same lowest pressure level. Peak pressure we match here. And then we increase the pressure to that higher level. And these pressures were matched and there were no problems with that. So we looked at what happens with trigger delays. Well, pressure support is slower to trigger than Nava is if you have patients who have dynamic hyperinflation, that's for sure. If you don't have dynamic hyperinflation and you have like patent airways, you might not see any difference because the flow will start just a few milliseconds after the diaphragm activity. So you will not see much of a difference. But what is interesting is that you can shorten the duration of trigger delay by half, and that is in pretty ideal situations. And in the worst case scenario, you will be like, if pressure support triggers as good as Nava, you will still be twice as fast. The cycle-off delays are affected by the assist delivery when you add assist, whereas the cycle-on delays have not been found by us, at least, to be affected by that. So cycle-off delays, if you increase the amount of assist, it's going to take longer for the ventilator to cycle off. And this is just intrinsic to a flow cycling off algorithm. If you give more pressure, you increase the peak flow, it's going to be longer time until you come down to the same relative level of flow. With Nava, you don't have any off-cycling delay because you cycle off when the muscle stops working. Now, what is the impact of this? Well, two. In pressure support, you are, I would think, setting your ventilator with an increasing pressure support until you see that the breathing frequency has come down to what you call good levels. So your respiratory rate is now down in the 20s or something like that. So if the patient started at, say, 35 and comes down to 20, you say this is good. Now, in Nava, we find that patients seldom goes below 29. In this situation, you see here, pressure support, tidal volume goes up. And why is it going up? Because the respiratory rate goes down, because you want to keep the minute ventilation. But this is, in fact, the hearing-Breuer reflex, because, as you saw in the previous slide, the delayed off-cycling puts an expiratory hold. If you have an expiratory hold, you release the hearing-Breuer reflex, and that slows down your respiratory rate. And because you deliver more assist, you are also getting a bigger tidal volume. So when you're lowering the respiratory rate here, you're just putting the patient to an arbitrary value that you feel comfortable with, but you have no clue what the patient would breathe at if it would be at that level. And what we found with Nava is that when we increased from a low level to a high level, no change in tidal volume, no change in respiratory rate. So the patient technically doesn't do anything. When the patient is within a comfort zone of assist, he's not in failure. He doesn't change tidal volume, he doesn't change respiratory rate. And that is because it's predicted by the CO2 receptors. Like your CO2 level is more or less what tells you what tidal volume and what respiratory rate you should keep. This is just another study. We show the same things in rabbits. The interesting thing is, though, here that when we came to very high levels of pressure support, which we couldn't get with Nava, if we increase the Nava level, we can't get the pressure up because the diaphragm activity disappears. But in pressure support, you get the pressure up. And what happens is you get a synchrony on top of the hearing-Breuer reflex. So now you can get your breathing frequency as low as you possibly want if you look at the ventilator's breathing frequency. And we have patients I will show you after lunch that was down at 8 in breathing frequency. So in newborns, things happen as we develop. So from us being the adult ones having an ideal breathing pattern like this when we are not talking, you see it down here. Towards the infants, it goes faster and it's more erratic. To the neonates, which is sometimes really erratic, has apneas, lots of sighs, sometimes variably up and down, but with a high rate again. So it changes from birth to age. Babies, if you look here, can have throughout the day, this is babies in an incubator, a diaphragm activity that can be very phasic and nice. They can also have apneas, huge recruitment maneuvers after the apnea, saying, I want to open my lungs. But they can also go into a series of sighs, lots of strange things that we've never seen. So when we started to do this, we wondered if there's something wrong with the electrode, is there something wrong with the amplifier, and so on. We thought, what's wrong here? But this is really the way small babies work. And then we come in and we set new modes like pressure support volume guarantee, or PRVC if you want. You have a mode that says, if I'm starting to do more effort, you take away the assist because your tidal volume should not be more than 4 ml per kilogram. Because you set the thing to do that. And is this right or wrong? I'm not going to talk about that, but I'm just saying that if you give support in proportion, then you will see tidal volumes go up when demand is increasing. And it will happen. And to just emphasize that a little bit, is just to show it's like some recent data we have from intubated babies, where you can see triggering of the ventilator when you're intubated. So the diaphragm activity starts, the assist starts, The diaphragm activity ends, the assist ends, and don't worry about those pressure waveforms are from a Servo 300, which we still use in our research. This is the prototype machine, not the fancy machines that you guys are using. You can see a small effort is giving low pressure, a big effort gives high pressure. Now, this slide is interesting because we take these babies off on a single nasal prong. And so with a leak through the other nostril and through the mouth, we ventilate them without PEEP, which a lot of people have a problem with. And what we find is that from a synchrony perspective, when the diaphragm activity starts, the assist starts. When the diaphragm activity stops, the assist ends. So we are synchronized. Number one here is that if I have a small effort, I get a small level of assist. If I do a sigh, I get the sigh. With a 80% leak, I still get the sigh. So the assist is there. And this is like to say, should we prevent that breath that the baby tries to use to open the lung? I don't think so. And if the baby do a recruitment maneuver, should he get what he asks for, or should we prevent it because we are more than 4 ml per kilogram? I don't know. But in this case, which is the worst case scenario, no PEEP and an 80% leak, we can still keep the synchrony and deliver proportional assist. So in that sense, I'm not going to go into the synchrony and leaks and non-invasive ventilation because I think I used up my time. But I think from what you see here, like that if you go into a situation when it leaks, as you saw in the previous slide, there is no difference to it. Thank you very much.
Thank you very much, Christer. This is open for questions. Christer, maybe I could ask a question while Rolf goes up there. You sort of asked the question, why do we have to set the ventilator if the patient can control their own ventilation, which makes sense. We can talk about cases where the patient is pathologic. Their control is pathologic. You know, best example would be patients perhaps who are comatose, not breathing. But there are other examples as well. So how do you address this?
Well, I think first of all, if we talk about lung receptors, which I think is the most important thing here, is that we use a lung injury model, which is that we put hydrochloric acid into the lung. That stops surfactant production, that causes edema, that causes burns. So there's like injury to the lung in all the worst ways you can think about. It's very acute. And when we do that, every study we have done, and Art will show this later this afternoon, every study we have done, we've done several of them, we can show that we can repair the lung over 3 or 4 hours or up to 6 hours without a problem, to the same level as if you would do protective ventilation, 6 ml per kilogram, optimizing the PEEP and so on. So if the rabbit can do it after having an insult of acid into the lung, these receptors are doing the right response as far as I understand. If this is true in an ARDS patient, I don't know. In sepsis, I sometimes doubt it because sepsis is a very complex thing. And it's like John says, we don't even know what it is. But if you have sepsis with a pH intracellularly, that goes low. You could even turn off the muscles. They cannot contract anymore because when you come down to a certain pH inside a muscle cell, it opens the potassium channels and just empties out potassium. And after that, it can't be activated for a long period of time. It just shuts down. And that's the survival mechanism of the cell itself. So in those situations, we don't know where to draw the line. But what you have here is that you see the activity. So you see the neural output, you see the synchrony, you see the pressures, you see the volumes. You measure them all. What you see, if you don't like it, then do something else. But if you have no problems with the volumes or the frequency or whatever the patient is doing, and he's doing it himself, why not let him work together with the ventilator, because you will apply lower pressures than you do if you would use other modes of ventilation.
Rolf?
You mentioned that you need not use PEEP, or you don't always have to, but I suspect there'll be a temptation to explore this, etc. I recall that lung volume has effects on the amplitude of the integrated EMG. Have those sorts of issues been sorted out? Does the gain of the system change when you change lung volume?
Well, I mean, if there's anything that would be negative in terms of that, is in babies you have something called, I think it's called Head's paradoxical reflex, which is a gasp reflex, which I think only occurs when you put a forced flow. So if you use like volume control or something like that, and you increase the flow rate, then you will release this reflex. When you have a person who is normal, except for Christer Ström, but he is not normal, because he has that reflex. He kind of tends to gasp a bit on Nava sometimes. So when you get something that helps you breathe in, it kind of gives a little bit of a runaway thing. You tend to take bigger volumes than you should. But you see it immediately. But other than that, I mean, the volume that we tried, like in studies, we tried to kind of increase the Nava level in healthy subject and make maximal inspiratory efforts to see if we simply could increase our inspiratory capacity. We could not. We were just shutting down the ventilator at the lower and lower diaphragm activity. We could not in any way do that. And I will show after lunch how you can see that you come to a plateau in volume where increasing Nava levels doesn't increase the assist that you get or the volumes that you take. And it's the same thing I just show you here in the pressure support versus Nava trial. Yeah.
So maybe let me ask you this different. Does the diaphragm electrical activity tell me about systems control of absolute volume over which I want to breathe? Basically, you're running the ventilator off the diaphragm EMG. Do we regulate the lung volume over which we breathe? And do we do it through a diaphragm EMG signal?
You have rapidly adapting receptors, slowly adapting receptors, and a lot of other receptors in the lung. They will regulate your breath in every breath in terms of the lungs size. The force receptors or the muscle receptors that you have will tell you if you're doing an excessive load or not. So if you say, okay, if the lung says, I should, because of my CO2, breathe with a tidal volume of, say, 500, but the muscle says there's no way you can do that because you're way too weak and you're not giving assist, I'm going to wind up with a tidal volume of 300 because otherwise I'm going to go into failure and fatigue. So I will instead retain CO2 as a compromise.
Do I regulate FRC with my diaphragm?
Right. So, Christer, let me
Yes,
rephrase it.
after lunch.
Okay.
Okay, you're going to deal with that. So the question is, can you set, and I know some of the results from the animal models, can you use Nava to set the PEEP level essentially? That's, I think, what Rolf is getting at.
Yeah, we will come to, I think half of the presentation after lunch will be about that. Yeah.
John?
Perhaps this is a little redundant, Christer, but I learned a long time ago when I was doing work of breathing studies and spirometry studies that sometimes you could get patients to take much deeper breaths if you ask them to relax their diaphragm. In other words, if I ask you to take the deepest breath you can, many people throw their shoulders back and do that. And then if I say, okay, relax your belly now and breathe with your diaphragm, there's actually more volume that comes in, a lot more volume if they do that. So you can't predict what the vital capacity is through a voluntary effort without further instruction. So I guess it comes on to the same question. You know, can you depend on the diaphragm always to tell you what to do? It seems logical if you assume that the diaphragm is the only engine for the system. But to the extent that there's disparity, can you really depend on the diaphragm?
To give you a short answer, no. But if you say in a bigger perspective, you could say if you are breathing and not using your diaphragm to an extent that I can measure with the methodology that we have been using, I've had subjects, healthy subjects, I've seen probably hundreds of them, and throughout the years, students, friends, whatever, whoever had to volunteer for these studies we have done. But I think I found one guy once who did not have any diaphragm activity until I did exactly what you said. I told him, stop using your shoulders to breathe because that's a very inefficient way of breathing. Sit down, relax, and forget about breathing. Just breathe the way you normally breathe because you don't think about it. Don't make it mental because it becomes like yoga. Yeah. You can actually breathe without using your diaphragm. Yeah. And I think in that situation, I think we've seen patients who are not using their diaphragm. And I showed you a few. And I think that in some cases, it's the interaction with the ventilator that forces them to not use the diaphragm. In other cases, it is that the patient is in pain, under severe stress, and so on. Yeah. And I would always say the same thing. Like, I mean, Nava is not anything that you have to do. It's just another mode of ventilation. It just goes on that extreme side of synchrony compared to volume control is the extreme side of asynchrony if a patient is spontaneously breathing.
It's tremendously logical, and I think these questions are going to be sorted out over time, whether or not it can be what we call in America the go-to mode all the time, yeah. Or whether there are special situations where we want to back it up or choose another mode. But your work is leading the field. I think it's really terrific.
Well, I think the thing here is to be, as you guys who are working in the clinic, I mean, this is just a bedside tool that is at the bedside today, providing you with something that many researchers have wanted for years and years and years and years. So it's just like an accident that in this case, Makia comes in and wants to do this thing and bring it to the market. Today now, the demand is, how can we measure this? How can we record this thing? And so now they want Makia to make this clinical device into a research device, which is kind of another story. But I think, in a way, I think it's, you see now what the patient is generating out of his brain. If there is no diaphragm EMG and you know the catheter is in the right position, well, you have to ask yourself, why is the patient not breathing? And that's the only question you have to raise. If you can find an answer to that, you have made a diagnosis. And I think that if they're breathing, well, then you can try to ventilate them. If you don't like what you see when you put them on Nava, then put them on another mode. Keep the monitoring those so you can improve the synchrony in that mode, because you can still do that. But I mean, every patient is their own case, and I mean, you cannot say that this applies to everything, and that's why I agree with John. Evidence-based medicine is not really a bedside thing. It's more like a thing where we try to say, is this really better or not? But it shouldn't be that every patient receives that therapy just because a randomized trial shows that. Yeah.
I think we need an RCT for this, whatever this is.
We are.
Thank you very much, Christer.